From Bhiwani, Haryana. The first topic is chemical injuries management protocols by Dr. Sunandini Bose.
Very good morning, everybody. I'm Dr. Sunandini Bose, and I would be speaking about managing the chemical injury cases, and I would be focusing mainly about the acute chemical injury. So we know that it can be caused because of alkali, acid, and even neutral agents. And in the last decade, because of the acid increased sales, so we see now a lot of cases in urban population as well as rural population. A lot of cases are for acid injury. So it is a very common form of ocular trauma that is happening in rural areas as well as urban areas. So coming to the positive agents, we know that it can be because of alkali and acid, and these products are very readily available in our household items also, such as lime or refrigerant, coolants, etc. So the severity of chemical injury depends upon the toxicity and the concentration of the chemical, the duration of contact with the chemical, the depth of penetration, the area of involvement or the limbal involvement, and the additional force and heat, etc. So before we learn to how to manage the chemical injuries, we need to grade them. So these are the widely classification that are used, that is the Roper Hall and the Dewars classification. Nowadays we use the Dewars classification more, which is based on the limbal ischemia and the conjunctival involvement. These are just a few cases where I'm just showing you, trying to show you that how you can grade these cases. So the parameters that need to be addressed are, you need to take a thorough history of the chemical. We need to know that what exactly has caused it. The first line of treatment is to do the inflammation control. So the primary goal is to reepithelize basically the ocular surface. And also you need to take the help of a general physician if you know that the patient has ingested or inhaled some toxic fumes. So the initial assessment starts from the eyelids, where you see the extent of blink and the extent of injury. For the ocular surface epithelium, you see the fluorescent staining, and everyday examination is must in these cases. So in the pictures, what I am trying to just show you is, in the first picture, if you see here, so you can see that the clear areas of limbal ischemia are is very distinctively seen. But in the second two pictures, you cannot see the limbal ischemia very nicely. That is because of the conjunctival hemorrhages that is masking the limbal ischemia. So most of these cases will have the limbal ischemia underneath the conjunctival hemorrhages. Also, please do not forget to take the IOP of the patient. Lot of times we forget to take it, and the patient lands up into a very bad glaucoma, and then it is very difficult to manage these cases. So the acute stage management starts with removal of the injurious agent, the assessment of the patient, control of the inflammation, and felicitation of the healing process, and that starts with the first line of treatment, that is the thorough irrigation. You need to do an irrigation for 30 minutes with 500 ml of balancer solution or any neutral agent, sterile neutral agent. Do put a topical anesthetic drug, and while you are doing the irrigation, make sure that the other eye is not getting a accidental chemical injury by flowing the water in that eye. So the type of irrigation fluid, I had already explained that it can be any sterile neutral agent, ringer lactate, balancer solution, and hyphoterin, which comes in a kit also nowadays, are very helpful. And you need to do a swab test so that the fornices become clear, and the slim blepharon does not form, and any issue that is having the particulate, you have to excise it. So the first line of treatment is over. Now we come to the medical management, that is the use of topical steroids. This is a main line of treatment. I'll show you in some of my cases that how a DEXA and a prednisolone will help in reducing the inflammation and further damage. Use a topical antibiotic so that a superadded infection is not there. Cycloplegics to relieve the pain. Anti-glaucoma if you're suspecting it is a high IOP. And lubricating eye drops for decreasing the mechanical rubbing and lubrication. Then in the later grades, if you feel that the epithelium is not healing, you can always use the oral therapy in the form of ascorbic acids and tetracycline. The most common drug that I use is a doxycycline 100 milligram BD, not in very young age group or a very old patients. And you can also use topical therapies in the form of N-acetylcysteine or reconstituted ascorbate also. So coming to the surgical management, tenoplasty or AMG, both tenoplasty and AMG, they are the first line of treatment in an surgical treatment. So what we generally do in this is you do the conjunctival peritomy and divide the tenous with the conjunctiva and advance the tenous onto the limbus, and you can just see in the last picture with this study that was published, you can see that the epithelium is getting healed in these cases. The next line of treatment is doing an AMG. So it has two benefits, that is a physical and biologicals. Physically, how to reduce the eyelid friction, and biological because it reduces the inflammation, it prevents scarring, it promotes the epithelial growth, and it prevents also the neovascularization. Procura is a prototype. It is a little expensive. You can have your own devices also that you can make. So this is one case study that was done for a sutureless contact lens type amniotic membrane. So I have used this kind of thing. So what you exactly do is you take the horizontal and vertical diameter and you fashion the AMG in your OT, and you put it in the contact lens. Take the contact lens, if the patient is in ICU and you cannot do the patient in the OR, you can just put it, in the bedside of the patient. So it helps with the patient if you are unable to do these cases. So these were some cases of the study has shown in infective keratitis. So this is one of my cases which was a grade 6 chemical injury. The patient was in ICU. I did not follow this method, but I just did Hakin method for an AMG on the bedside. So this is a healing process. Now what I want to show in this is you have to understand that after the healing also the patient will need a lot of other care also, and the patient might need many more setups of AMG. So the early stage of managements are the topical steroid, lubricants. In grade 3 to 4 as called the oral therapy, and in grade 5 to 6 the surgical therapies. So these are just some of my cases where I have done the treatment, and you can see that just with a prompt treatment you can have the next day patient is and the epithelial defects are healing. This is another case you can see after the next day with the same treatment line, you can see that the epithelium defect have reduced widely. This is another case where it was a battery acid that was going inside the eye. You can see in 3 days with the same treatment, irrigation and topical steroids, the patient healed very nicely after 1 month. And this is the other eye where you have to use a BCL if the patient had a lamellar injury also. So the late stage management is a multidisciplinary action. You have to take care of the eyelid, you have to take care of the dry eye diseases, limbus tunnel deficiency, slim brephron, high IOPs. So this is one patient where I had done a simple excision of the granuloma and the slim blepharon and just did a AMG. The patient was not ready for a slit, and this is the 1 month picture. And slit, we all know that it is a late stage thing. So to summarize, we need a prompt eye washing and irrigation. Steroids are a must. You have to monitor the patient daily and do not be afraid to do a tenoplasty or AMG. Thank you.
Thank you, Dr. Sunandini. Thank you very much. Anybody wants to ask any question?
So ma'am, generally what, I practice in a multi-speciality setup. They are my own setup. So I see a lot of patients who have, inhaled these toxic fumes, and the patient is having burns all over the body. So that time you cannot take the patient to the OR because the patient is not hemodynamically stable. So the first line is just to, if you have started the therapy, the medical therapy, and you feel that the patient is still not, ready to go to the OR, you can just put it as a first line thing. And as I said that, most of the patient, if the initial therapy has not started within 24 hours, they will need at least 2 settings of AMG. Because the first setting of AMG, we tell the patient that this is just for the stabilization. Some area is going to heal, but the vascularization is going to go up because the first 24 hours, the steroids and the irrigation has not happened. So the inflammation has actually set in. So that is why you have to do the irrigation and start the steroid. And this is just the first line. And then you can always tell the patient that you will need another AMG or a slit later on.
Thank you, madam.
Yes, they will. So ma'am, generally these patients are lying on the bed. They are not much movable. And in the first 7 days, if I feel that the BCL has come out and the surface has not healed, I will do an AMG after that 7 or 10 days again. when I'm putting the BCL in the patient, I tell them that this might come out, but this is just a temporary thing because we cannot take you to the OR, and we might have to repeat the surgery after 10-15 days if this is not working.
Thank you, madam. Thank
you
you.
so much, sir.
Thank you, Priyam. Now we have Dr. Ashok Sharma from Chandigarh. Tips and tricks for removal of deep stromal foreign bodies.
Good morning, everybody. From chemical injuries, we move on to the mechanical injuries, and we all are aware that the corneal foreign bodies is a most frequent problem all of us encounter. But unfortunately, the deep intrastromal corneal foreign bodies are relatively rare, and we get cases in which all the removal have been tried. To manage these deep corneal foreign bodies, we need to ascertain the plane of the foreign body. So we have to have the detailed slit lamp biomicroscopy, and these days we can also do the anterior segment OCT. And depending upon the level of the foreign body, sometimes if we have to do surgical intervention like lamellar pocket and then removal, we have to decide that. Anterior segment OCT is very handy. This is the first picture is pre-op metallic foreign body in one of our patients. The second one is after the removal, and third one is a caterpillar here in the corneal foreign body. So anterior segment OCT gives great details and helps in the management. Now I will be showing 4 cases which we have managed. The first one patient is a 9-year-old girl. She presented to us after falling on a bush, and presentation was after 3 days. And this foreign body was in the anterior stroma only. It was lying horizontally. So the management is simple, that you just de-roof, remove the foreign body, and give the topical antibiotics and antifungals. And the patient was like, because it was off visual axis, the visual result was also better. Now I move on to some of more interesting and more challenging cases. Now this patient had a wooden foreign body which was in the anterior and mid stroma, and it was very difficult because wooden foreign bodies we have to remove in toto, otherwise there is no use, because residual wooden foreign body will lead to fungal infection. So we thought we will widen the track, and we may put some visco or some BSS and it may float out, which is not possible. So idea struck that we have retinal foreign body forceps which our retina colleagues use to remove intraocular foreign bodies. I introduced one limb of this foreign body forceps and engaged this foreign body into the concavity of this forceps, and taking care not to let it go out and break, we removed it in toto. Care should be that once you are removing, you keep on pressing the foreign body onto the anterior stromal layer so that it doesn't come out of that concavity. The next case in patient you will see is more challenging. We have a young patient who again fell on a bush, and he had 3 vertically oriented wooden foreign bodies, and they were up to deep stroma. There was no way to remove them from externally, so we thought we'll go for the combined approach for these corneal foreign bodies. We had at that time no special instrument designed to it, but we can also design it. But in this patient, since we decided in the OT only that somehow we have to remove, so we entered into the AC. You can see the head of all the 3 wooden foreign bodies which are vertically there. So after filling viscoelastic into the anterior chamber, we thought we'll press from the inside, and the stroma will be compressed, and then we will be able to remove these foreign bodies. So this method we tried in these foreign bodies, and you can see once introduced, we are going to press from behind, and the stroma will be compressed, so we can pick up the foreign bodies one by one. This is the first one. Now this is the second foreign body. And now this is the third foreign body. Since this was our first case, after that we have refined the process. We can always bend the cannula, or we can also use a silicone tipped cannula which our retina colleagues they use. So this method was very useful to remove these vertically oriented stromal foreign bodies which otherwise would not have been possible. After removing these full thickness foreign bodies, it is always better to check for the intraocular penetration, and in this patient, once we checked, there was intraocular penetration, perforation, so we applied synovial tissue adhesive, in this patient, and it virtually healed without any problem. So it is always important in case of wooden foreign bodies that we remove them at the earliest and in toto, and also give these patients antibacterial and antifungal drops prophylactically. The simple way of putting the tissue adhesive, only care we take is we apply the minimum adhesive and we remove the epithelium. Since in this patient we had no corneal ulceration, nothing, so we used glue only to remove the epithelium. The first time we applied the glue, we removed the glue so that the epithelial debridement occurs, and second time we applied little bit of glue, and then the things are taken care of. The minimum possible glue which seals the perforation is required. Excessive you can always soak out with the cellulose sponge or with the cotton. So, sorry. We have the third case. Now, in this patient, we had metallic foreign body, and we thought we have a lot of experience, we will remove it externally. But you see, I was holding the foreign body, but was not able to pull it out of the stroma. And the reason I will explain later. So we thought we will widen it, and we may go the same way as we remove the vertically oriented foreign bodies. We will try to push it from behind, and we will remove that. So after filling the anterior chamber, now we had also become wiser that will not use like iris repositor that is a broad end and it does touch the larger area of the corneal endothelium. Although in that patient we didn't get any endothelial decompensation, patient is still with us, and we bent the cannula and we tried to remove the foreign body. So this attempt also was not successful. This was not successful by internal and external technique, and in this maneuver now you can see the cannula tip, but there is no foreign body. With this maneuver the foreign body has gone into the anterior chamber, and then you can see the foreign body lying on the lens itself at the margin of the pupil. And again for this foreign body retinal forceps came handy. And with the retinal forceps, taking care not to injure the lens and not to entangle the foreign body in the iris, we removed it. This foreign body was a metallic foreign body, and this you can see the irregular edges of the foreign body. So this was the reason we were not able to pull it out through the stroma, although we increased the incision and we tried that way. In this one we have to be careful that we don't engage the iris or don't injure the lens. We can go slowly and we can remove that. You can see the foreign body now. So these were the 4 cases. The first one is this one. We could publish this in IGO, and the second one also we have published. The third one we have already finalized the manuscript and we published it. So in the end I would like to say that for deep wooden foreign bodies the total removal at the earliest is desired. Small foreign bodies, wooden particles, and in the anterior middle stroma we can use the scoop technique using the retinal foreign body forceps. Horizontal wooden foreign bodies, deroofing technique is useful. And for vertically oriented full thickness foreign bodies, we need to use combined intracameral and intracorneal approach. And cyanoacrylate tissue adhesive is required for corneal perforations. Prophylactic antibacterial and antifungal treatment is desirable. Thank you.
Thank you, sir. Very nice presentation. We have learned from what you have shown. So thank you, sir. The next speaker is Dr. Ramanuj Samanta. He will speak on management of post-traumatic retained intraocular foreign bodies, case-based practical approach. Please note that time is 7 minutes and you will get the bell after 6 minutes.
Thank you. Thank you, AIS, for the opportunity. So we have shown some nice, elegant videos by Dr. Ashok sir for removing the corneal foreign bodies. So what about the posterior segment foreign bodies? So IOFB may be multiple in number in up to 25% of cases, and the commonest location is posterior segment. The most commonly it's metallic, and most commonly they enter through the cornea. The commonest mode of injury is through hammering. So when we suspect posterior segment intraocular foreign bodies, if we see some focal lens opacities, iris transillumination defects, iris heterochromia, or small self-sealing wounds, we would suspect that there is possibly some intraocular foreign bodies. So there are various imaging modalities. Plain X-ray is a good screening tool. CT scan has high sensitivity, can detect multiple IOFB. MRI has a good, better visualization, but is avoided in magnetic IOFBs. USG helps in surgical planning especially. UBM and ASOCT is especially for anterior segment or sulcus foreign bodies. So we can see X-ray can pick up, is an easy screening tool, but sometimes X-ray can miss some foreign bodies that the CT scan might help. USG provides additional information about the posterior segment. You can see there is post-acoustic shadow, there is presence of incomplete PVD and vitreous hemorrhage, and also helps to rule out retinal detachment. So the timing of IOFB can be early or late. Early IOFB removal from posterior segment, the wound visibility is more difficult. Posterior hyaloid removal is more difficult. There is more risk of intraoperative hemorrhage, but the risk of endophthalmitis, metallosis, retinal detachment, and lawsuits are less. So there are two routes, generally transcorneal and transscleral, I will show in the videos. So let us come to some videos. One of the first case was the foreign body lodged in pars plana region. So after we can see that injecting triamcinolone acetonide posterior vitreous was, PVD was induced, thorough vitrectomy was done. So in this patient, the foreign body was lodged in the pars plana and there was vitreous incarceration. So you can see the foreign body. So we removed it after vitrectomy through an external cut down with an MBR incision, and we can remove the foreign body through the external route with a simple McPherson's forceps. So coming to the second case is an encapsulated IOFB impacted at retina with siderosis. So in this patient, so we can see there is presence of foreign body in the inferonasal retina with some siderotic changes. So here it is important to remove the hyaloid and free the foreign body from the surrounding retina and remove the encapsulations around the foreign body, gently tease out the foreign body. You can use some PFC in the posterior pole so as to not to hurt the macular region. Then after gently dissecting out, sometimes if it is late presentation, it can get encapsulated. It's lifted with the magnet, and we have already done lensectomy, preserved the anterior capsular rim, and with a bimanual handshake technique with intraocular forceps, we have extruderized with a limbal wound. And here the anterior capsular support is present, and you can always implant an IOL in the same settings as in this case for visual rehabilitation. Third patient is an IOFB impacted at macula with VH, subretinal bleed, and clear lens. So in this patient, there was the foreign body was just juxtafoveal region, and there was presence of subretinal bleed, VH. We just teased out the foreign body gently, taking care not to damage the fovea. And after we have freed the foreign body, we gave an incision external, again tried to save the lens. But when we tried to took out with an intraocular forceps, it got entangled in the pars plana region. So we gave another small incision, took the magnet, and just lifted the foreign body into the mid-vitreous cavity with the help of magnet and took it out with the forceps by bimanual technique handshake. The lens was well preserved. There was no need of lensectomy and gentle laser, and the patient achieved good vision. The fourth patient was IOFB at retina. There was also retinal detachment, and the patient had traumatic cataract. So here the foreign body was large. We did lensectomy. Then we went ahead with the complete vitrectomy, ensuring the complete removal of the posterior hyaloid. You can see the foreign body is in the inferior mid-peripheral retina. Triamcinolone acetonide was injected. Posterior hyaloid was removed, and you can see some star folds. PFCL was injected to flatten the retina. Lensectomy was completed, and then again we preserved the anterior capsular rim, teased out the foreign body from the retina, and once you have freed the foreign body, you can lift it with either with the magnet or with the intraocular forceps. And when it was in the anterior and over the anterior capsular rim, then you can take it out with again a bimanual technique with the help of a forceps. Now there was a star fold, so we need to do a relaxing retinotomy to prevent free retinal detachment. So once the relaxing retinectomy was done, the retina was free. Now we can put oil tamponade and the retina was attached. Last patient is an IOFB at ciliary sulcus. So this was an interesting patient referred from elsewhere. There was a focal lens defect, focal iris defect, and the patient underwent an X-ray. No foreign body was seen outside, but we had a high index of suspicion, so we did CT. Foreign body was seen. So when we did gonioscopy, we could see the foreign body lodged in inferior ciliary sulcus. So what we did for removal is in this patient we did and gave an incision with an MBR for an AC maintainer. Once we have introduced the AC maintainer, we tried to take it out through the iris hole with directly with the magnet, but we could not get hold of the foreign body with the magnet. So what we did, we introduced two more ports and introduced iris hooks and expanded the area. Now with the help of a muscle hook, we depressed, and with the help of a foreign body posterior segment forceps, we took it out the forceps and exteriorized the foreign body through the limbal wound. So we also published this case in BMJ. So these are the complications. So in conclusion, high index of suspicion is required to diagnose intraocular foreign body. Appropriate imaging, mostly USG plus X-ray and or NCCT orbit is sufficient. Appropriate instruments should be made available according to the nature of IOFB prior to the surgery, and management should be customized according to the cases. So this was the last case I operated this week only. This was a foreign body which was a nail completely impacted through the cornea into the retina. You can see in the CT scan going from right into the anterior to the posterior cords, and when I removed it, it's more than 3 centimeters. So you need to have proper instrumentation and proper planning before the surgery. Thank you for your patient hearing.
Thank you, Dr. Samanta. Next speaker is Dr. Vineet Kumar Bhatwani, Retina Intraocular Foreign Body Clinical Manifestation Diagnosis and Management.
Good morning, everyone. More or less, my talk is entirely covered in this only. Can I have the PPT?
Next one, Dr. Manish Wankhede. Dr. Nanda, Prashant Nanda. पीछे Dr. Nanda, are you there? No. Dr. Priyam, your slides are there?
Good morning, everyone. I am Dr. Vineet, Senior Resident at Dr. RP Center for Ophthalmic Sciences. I am going to present retained intraocular foreign body, its diagnosis and management. So most of the IOFBs, as already discussed, have been reported in about 10 to 41% of open globe injuries, and 75% of these lodge in the posterior segment. So retained intraocular foreign bodies most commonly result from occupational activities, generally a hammer chisel injury. They predominantly involve males who are the working population, generally in third to fourth decade of life. 90% of IOFBs are metallic, of which about 55 to 60% are magnetic. So coming on to the basics of the foreign body, first of all, classifying on the basis of the anatomical zone involved, they can be within the corneal limbus, which involves zone 2, 5 millimeter beyond the limbus, which is zone 3, and beyond 5 millimeter, which is zone 3. So depending upon the zonal involvement, the after effects of the foreign body also matter. So depending upon the nature of the foreign body, they can either be toxic to the eye or inert. Among the toxic foreign bodies, the most common one being metallic ones, the iron, the steel, the copper and the aluminium. And vegetative matter generally leads to post-traumatic endophthalmitis, which becomes again a significant complication of foreign body. There are certain foreign bodies which are inert and may not need any intervention for their removal. So on the basis of the position of the foreign body, they can either be lodged over the cornea in the anterior chamber, within the lens, in the ciliary sulcus, or in the posterior segment, or inside the retina. So how does a foreign body cause a damage? Either there can be a mechanical damage, there can be introduction of some infection leading to endophthalmitis, there is a reaction of a foreign body, some amount of iridocyclitis, or a sympathetic ophthalmitis in a long term. So coming on to the reactions of intraocular foreign body, it can either be an exudative or a fibroblastic reaction, or chemical reaction, or a proliferative response. So the specific reactions generally most commonly encountered foreign bodies are the copper and the iron. The copper, depending upon the amount of copper content, if it is more than 80%, it is associated with suppurative consequences leading to iridocyclitis, cataract, retinal detachment, choroidal abscess, and phthisis. If the copper content is less than 85%, it leads to chalcosis associated with green-blue ring around the cornea, sunflower cataract, and also impregnation of zonular fibers. So iron is another most important foreign body that can cause a whole lot of damages, counting from cornea to the posterior segment. So endophthalmitis is most commonly encountered complication with the foreign body. There is an increased risk related with the presence of a retained intraocular foreign body, and a delay in the wound closure beyond 24 hours increases the risk by 1.3 to about 60%, as mentioned in various studies. So it is generally associated with virulent pathogens like Bacillus cereus, Staphylococcus, fungus, and polymicrobial. Therefore, these patients generally get a poorer prognosis. So coming on to the management, basic examination needs to be carried out for all the patients. The baseline visual acuity, pupillary reaction, IOP, external examination, and slit lamp, and the assessment of media clarity is one of the most important things that has to be done. Most of these cases are the medical legal cases, so proper documentation of such cases is needed to be done. Then we have to localize where exactly the entry point of the foreign body is, and there are other subtle ocular signs like lenticular opacity, cell-seal corneal wounds, size of the pupil, etc. that can give us an idea. These are basics of the investigation that a patient undergoes. X-ray orbit helps in locating a foreign body, and for a localization we can use a circumciliary ring. Ultrasound can be done. CT scan is one of the most sensitive investigations, and a UBM can be done for anterior foreign bodies. General management of the patient involves the tetanus immunization of the patient if already not done, the primary wound repair, and pre-operative antibiotics including third, fourth generation fluoroquinolones, and intravitreal antibiotics if we suspect a high risk of endophthalmitis. So what affects our surgical decision? This is the composition of a foreign body. Either it is inert or is it reactive. Any signs of endophthalmitis or infection present in the patient, associated retinal detachment or vitreous hemorrhage, and availability of appropriate setup to manage the foreign bodies. So are we still removing all the foreign bodies? So there lies a gray zone where certain encapsulated foreign bodies or the foreign bodies having an inert characteristics in a patient with good visual acuity relatively and no retinal complications still needs a brainer decision like whether we need to remove it actually or not. And if there are signs of endophthalmitis, they definitely require removal. So management, basically anterior chamber foreign bodies, a separate wound needs to be made apart from the main entry wound, and the foreign body can be dislodged from any attachments if they are present and removed. Intralenticular foreign bodies can either be with the clear lens or they can be associated with a cataractous lens. In a clear lens, if it is a toxic foreign body, that is a reactive foreign body, it definitely needs a removal. However, if it is an inert foreign body, still lies a gray zone whether we need to intervene in a patient with good visual acuity or not. Then if a cataract is present, definitely removal is advised. Then there are basics of the surgical steps that we need to do. We need to ensure a good visibility of the foreign body. So for that we need a dilated pupil and a cataract needs to be removed. Then the core vitrectomy is done to free the intraocular foreign body, and depending upon the size of the foreign body, we use various instruments and define the route of removal of such foreign bodies. So here are two of my cases.
Successful combined.
So the first one is a 10-year-old male who came to us with a history of trauma with a metallic object. He had the cataractus lens along with the foreign body which was seen on X-ray as well as CT scan. So we planned combined lens aspiration with 23 gauge pars plana vitrectomy with intraocular foreign body removal. We could see an entry wound in the cornea associated with some iridocorneal adhesion. So we went ahead and did the cataract surgery for this patient using our 23 gauge cutter and lens aspiration. Then we detected a gap in the posterior capsule indicating the pathway for the lodgement of foreign body. Then we did the core vitrectomy. We freed the foreign body from its attachment. PFCL was injected to protect the posterior pole. Then the intraocular foreign body was removed from the anterior route as we had already removed the lens and with a preserved anterior chamber. So using a handshake technique, it was again removed. Then we planted a multi-piece intraocular lens in the sulcus so as to provide visual rehabilitation. Then though the retina was attached, but still we did a prophylactic laser around the second case is again an adult who came with the cataract along with retinal attachment and intraocular foreign body. So we passed an encerclage as we already knew that there was retinal detachment present posteriorly. Again we did the lensectomy, removed the lens, and then we did the core vitrectomy, ensuring the foreign body is completely dislodged from its attachment. The foreign body was pretty much anteriorly present. The foreign body was removed using the intraocular forceps. And then following the removal of the foreign body, again a multi-piece lens was implanted. Then the retina was taken care of. Under the PFCL, ILM peeling was done. The retinotomy was made, and the retina was settled using an air gas exchange, and the laser was done subsequently, and followed by the closure of conjunctiva. So these were two of our cases in a small practice that I have done till now. So these were two of my videos that I needed to show. Thank you.
Thank you, Dr. Bhatwani. Next is Dr. Priyamvada Yadav from Rohtak. Myriad mechanisms, presentation and our role in pediatric ocular trauma. Dr. Bhatwani, please stay till the session ends.
Pleasant morning. So I'll be talking about the myriad mechanisms, presentations of pediatric ocular trauma and our role to save their sight. So pediatric ocular trauma is quite common in developing countries where children from both rural and urban areas are affected by myriad mechanisms both at home and outdoors. So I'm presenting few cases of pediatric patients under 15 years of age who presented to a tertiary care center, suffered ocular trauma either at home or outdoors by a variety of objects, which were mainly penetrating globe injuries with some extraocular injuries as well. So we are describing the profile in terms of the mechanism and the injuring object, the time of presentation following trauma, the management, and the final visual outcome and sequelae. So case number 1 is of an 8-year kid who got injured with seizures at home while playing, while his parents were out for daily wages work. The child was brought 6 hours following the injury. So we found a corneal tear with multiple flaps, as you can see, along with presence of a traumatic cataract. So after the fitness, tear repair was done. So this was around 12 hours. So 6 weeks later, cataract extraction was done with a sulcus fixated IOL implantation. At 3 months, the BCVA in the affected eye was 618 with a normal intraocular pressure. The child is currently on amblyopia therapy. Next is a case of an 11 years boy from rural area who got injured accidentally by wooden stick used as arrow while he was passing by. There was a corneal tear with fibrin and traumatic cataract. The child was brought 6 hours after the injury. Tear repair was done along with intravitreal antibiotic injection after 6 hours following fitness. And the eye was followed till it became quiet. Cataract surgery was done after the eye became quiet after around 2 months, and the best corrected vision in this eye was around 6/6 part at 3 months with a normal intraocular pressure. Then an 11 years boy who got injured by a flying hockey stick while he was passing by. He was brought 3 hours following the trauma. There were multiple orbital valve fractures with a canalicular tear, upper and lower lid marginal tears with conjunctival tear and traumatic mydriasis. So we did an exploration and repair after 8 hours. The child had quite good cosmetic results, 2-month post-repair, and the BCVA at 3 months was 6/6 part with a normal intraocular pressure. This was an 8-year girl. Actually, we have seen a similar kind of patient in one of the previous presentations. So there was a history of trauma by vegetative matter, JOAR, in this case, 3 days back before the child presented. So, and the child was using already some eye drops given from some local practitioner. The vision at presentation was 618. So, on examination, there was an intracorneal foreign body with presence of anterior chamber reaction, a pharmacologically dilated pupil, and good fundal glow. So, we removed the foreign body and the tear was repaired. The vision was 6/6 with correction following suture removal with some astigmatism at 1 month. At 3 months, this was good with the normal intraocular pressure. Then is a case of an 8 years boy who got injured by wood while playing, was brought 1 day following the injury. There was a corneal tear with sphincter tear and traumatic cataract with a vision of counting finger 1 meter. The repair was done after 6 hours. The traumatic cataract extraction with IOL implantation was done 1 month following this. At 3 months, the BCVA was 618 with astigmatism. Then a 10 years boy who was brought to us 5 days following trauma by iron rod while playing outdoors. He had a corneoscleral tear. This was actually time because the tear could not be seen, maybe because of the circumstances or ignored or neglected. So there was a corneoscleral tear with fibrin post-op day 1. After repair, we found a shallow anterior chamber. We did a pad patch for this patient. Post-operatively, 1.5 months, the child was doing good. At 3 months also, the vision and ocular pressure were fine. Then a 6 years boy injured by wooden stick while playing when his stepmother was not around. There was a corneoscleral tear with a traumatic cataract. A 12 years girl from a rural area of another state. She was brought 3 weeks following trauma by a branch. In this time, she was given treatment by some local practitioner for 2 weeks. Then the child was referred, and after referral, she came to us 1 week. 1 week after the referral. So at presentation, this was the picture, vision of hand movement. There was a sealed corneal tear with whole anterior chamber full of lens matter. Now, this is something that is not acceptable. We can see grossly what is there in the eye. So this has not to be missed. There was an intraocular pressure of 32 by non-contact tonometry, and there was a cataractus lens on ultrasonography. So we did a tear repair with anterior chamber wash. After 2 weeks, when the eye was quiet, and IOL implantation was done. At 1 month, the vision corrected vision was 618 with normal fundus. At 3 months, she had the best corrected vision of 6/9. So the child is on regular follow-up for intraocular pressure along with a regular disc examination because she has been under that much high intraocular pressure for quite long. Next is the case of a 13 years boy who fell accidentally stumbling over a bench at home. The child was brought within 1 hour of injury. There was a limbocorneal tear with uveal prolapse, and it was repaired after 4 hours following the fitness. At 3 months, the vision was good with a good intraocular pressure. And the last case is of a 5 years girl who got injured with pencil while fighting with a sibling at home. The child was brought 4 hours after the injury. There was a corneal tear with uveal prolapse. Repair was done 6 hours following the fitness. At 1 week post-op, she had a vision of 624 part with a normal fundus at 2 weeks. The best corrected vision at 3 months was 612 part with a normal intraocular pressure, and she is currently on amblyopia therapy. The conclusion here is that pediatric ocular trauma is common, can occur by myriad of mechanisms and objects. A thorough examination, timely and optimum management, and if we find it out of our scope, the patient has to be referred timely to save the useful vision and quality of life of the patient. Protective and preventive measures to prevent the mishaps leading to ocular injuries, their importance cannot be underemphasized. So awareness regarding different mechanisms of trauma, prevention by following appropriate measures, particularly the prevention, now protection of the other eye. Once the child has suffered injury in one eye, that again becomes very important. Timely presentation to a healthcare facility with optimum management, preserve the vision and quality of life of children. This is very important to reduce the social and economical burden on the family and the society. So I'm thankful to all the patients who entrusted us with their treatment and the residents of PGIMS Rohtak, Haryana, who left no stone unturned for the fitness of these patients for their timely management. Thank you so much.
Thank you, Priyam. Just stay for a moment. Dr. Dinesh, please come for your presentation. Dr. Dinesh is past president of Punjab Ophthalmological Society. There's a small question for you, madam. You have written in case number 7, stepmother was not at home.
Yes.
So why did you write that? Stepmother was not at home.
Yes, this is
And what is the importance of that?
Yeah, the importance here is because there can be two things. One, the child is neglected or ignored because of reasons, like they are not able to see, like one of the cases that something has happened, or because of their family circumstances, they cannot bring the child. Here, I have particularly mentioned this because in one of the cases out of these 10 was a stepmother. Okay, maybe she was not that much, bond might not be there towards that child. So 1 in 10 cases, maybe there can be such cases, but then rest of the 9, these were children, like where there was no such condition, and still we saw lots of neglect and ignorance on part of, I must not comment, but mainly by the patients, but in few cases, our own colleagues, like where there has not been timely referral. So all these factors actually have to be taken care of and well in time.
Thank you, thank you.
Yeah, thank you.
हम बच्चों को जब स्कूल में जाते हैं लेक्चर देते हैं तो ये बोलते हैं उनको कैंची, प्रकार, छुरी, ये बच्चों की पहुंच से दूर होने चाहिए. जैसे इन्होंने बताया, एक केस दिखाया कि कैंची लग गई बच्चों को. That is prevention of cornea.
Thank you, sir, and thank the AIUS for giving me this opportunity. I am presenting 2 cases of trauma, and one of these is a penetrating trauma and the other one is a blunt trauma. So I come from Ludhiana. The Birmingham Eye Trauma Terminology System says there is a open globe injury or a closed globe injury. So we'll have one case each from both. Closed globe can be a contusion or a lamellar laceration, and an open globe can be a rupture, laceration, penetration, perforation, and a retained intraocular foreign body. So my first case is a boy. Video is not working. Came with the retained intraocular foreign body, and it was going through and through the cornea as well as rupturing the lens and lodged into the posterior side. So what we did was we made the interior entry wound into a CCC. The corneal, of course, the cornea was stitched before, and even the posterior entry wound as a posterior CCC with the help of a cutter. So this was at the primary surgery level. Then we went ahead, did a pars plana vitrectomy, removed the foreign body with a hand roll technique, picked it up with a magnet and the forceps, and closed the case with the silicone oil. At 2 months interval, when we were going to remove the oil, in this situation, the silicone oil is already removed. So we separated out the 2 anterior as well as the posterior capsular remnants or the anterior and posterior CCCs, and implanted a hydrophilic lens with 4 haptic into the bag. So this lens has actually gone within the 2 anterior and posterior capsular rims and into the bag. And this patient has been following with us and has a best corrected visual acuity of 6, 12 and 6. This is now more than a 6 years follow-up. So the lesson we learn from here is that initial planning and the way we go ahead with surgery is very important in all cases of trauma actually. The second case is a 27-year-old male who presented to our center 1 month after a water jet injury. He was working in one of the Gulf countries and he came for treatment after he probably got some first aid treatment there and then realized that the cost of treatment is very high and he doesn't have a family there, so he came to Punjab again. On presentation, his left eye visual acuity was 660, which was not improving, and he had a post-traumatic cataract with more than 180-degree iridodialysis and a secondary glaucoma, which was 32 millimeters of mercury. So we operated him for phacoemulsification with IUL with repair of the iridodialysis.
Under local anesthesia, 23 gauge pars plana cannula was placed in infratemporal quadrant 3 millimeter away from the limbus and was plugged.
To place a pars plana cannula.
Phaco ports were fashioned.
Although we didn't use it later on. Main port, side
2
ports.
superior capsular hooks were placed through 24 gauge needle openings to retract the large iridodialysis out of the field of phacoemulsification. CCC was fashioned and hydrodissection done. Phacoaspiration was done.
This was a routine phacoaspiration with IUL implantation.
Vitreous tag was cut using vitreous cutter and anterior chamber was cleared of any vitreous. CTR was inserted to take care of superior zonulodialysis. Single piece, foldable, hydrophobic, acrylic IOL was dialed in position and IA was done to remove the cortical matter.
This is the phaco part.
Hoffman pocket was made superiorly. MVR entries were made opposite to Hoffman pocket to pass straight needles of 9O polypropylene suture. Iridodialysis was stitched at 6 points
Different points.
using 3 polypropylene sutures. Straight needles of 9O polypropylene suture were passed through the iris by railroad technique using 30 gauge needle.
So here we use 30 gauge needle. You can easily catch hold of 9O. You can do this. 2 points of attachment. Another 2 points, and then one on the nasal side.
Viscoelastic was removed by irrigation aspiration and AC was formed by corneal hydration of ports.
And the cannula was removed as a last step.
And 23 gauge pars plana cannula was removed.
So then in the postoperative period, he again had a rise in intraocular pressure and underwent a TRAV with Mito within 1 month of surgery. And at the last follow-up, when he came at 2.5 months, he had a best corrected visual acuity of 6.6 and 6 with an intraocular pressure of 18 without any anti-glaucoma medications. And he's probably returned back to work and is not reported for follow-up later. Thanks.
Thank you, Dr. Dinesh, for your wonderful presentations. Last call again for Dr. Manish Wankhede, Dr. Prashant Nanda. So they are not there. So all of the presenters, please come forward for a photograph.